Welcome everyone. Today our second OSPE class. I am Dr. A B Siddique, working as a assistant professor of surgery in Shohid Tajuddin Ahmed Medical, Gazipur. Today we will discuss about the contrast X-ray. Before going to slide contrast X-ray, preliminary we want to know what is contrast X-ray, the in and what are the benefit of contrast X-ray and what are the root of using contrast. In case of contrast X-ray, actually we see in X-ray the radio opaque shadow, the radio opaque substance like bones, stones, or those are the radio opaque. These radio opaque substance we can see in contrast X-ray. We can see in plain X-ray, but we cannot see the viscera. We cannot see the viscera, GI tract by plain X-ray. If you do an plain X-ray, if you want to see the esophagus, you cannot see anything. But if we use dye that is radio opaque, uh, then we take the X-ray, then we can diagnose some disease that help us to diagnose or reach a diagnosis of some disease. So we use contrast to see better, to see some structure that are usually not visible in plain X-ray. So in contrast X-ray, usually we use contrast or dye, and there are three route of using dye. One is oral route, another one is IV route, and the another one is rectal route. In case of X-ray, like plain X-ray, if we use contrast or dye like oral dye, that is the barium sulfate, if we use the barium sulfate, we can see the whole GI tract by using this modifying this plain X-ray by adding some dye. We can see the whole of the GI tract like esophagus, stomach, small intestine, large intestine. And again, in case of CT scan, this is also X-ray. CT scan is also a X-ray, and we can use dye in CT scan both oral route and IV route, and we can visualize the visceral organ more perfectly and more accurately. Even in MRI, sometimes we use dye to visualize and to more accurate diagnosis. This will help us. So this is the preliminary this is the contrast, that is the dye we use to visualize some visceral structure that is usually not visible on plain X-ray. So today we will discuss about this contrast X-ray. And before going to contrast X-ray, we also want to something like that. uh, Contrast X-ray, if we use in oral route, usually we use barium sulfate, and this barium sulfate is passing from mouth to anus by, it is the time dependent, when it goes to the esophagus, when it goes to the stomach, when it goes to the small intestine. And in case of large intestine, we usually use parectal dye. So to visualize the esophagus, we want to take the X-ray when it is retained in the esophagus. But if it is goes to the stomach, and if we can take this X-ray then we cannot see the esophagus. So when we want, you have kept in mind that when it is in the esophagus, when it is in the stomach, and when it is in the small intestine, and according to the time we take the X-ray to visualize the esophagus, to visualize the stomach, to visualize the small intestine. If the dye, if we want to see the stomach, but we can take the X-ray immediate after taking the barium, we cannot we see the stomach, but we can see the esophagus. So time is important. uh, the dye, the introduction of the dye, the ingestion of the dye and time is also important. What structure you want to see, and what time it retain in the esophagus, in the stomach, in the small intestine. So time is very important. And again, we use, in case of CT scan, we use both oral dye and also IV dye, and the time is also important. And we, what we want to see, it is also important. So the timing, according to the timing, the in oral route, the dye is the same, the barium sulfate. But when you want to see the esophagus, then it is called barium solo. It is called barium solo X-ray. When you want to see the stomach, then it is called uh, barium meal X-ray. And when you want to see the small intestine, then it is called barium follow through. And when we want to see the large intestine, then it is called barium enema, as we use the dye parectal route. So the same dye that is used to visualize the GI tract, but according to the pathology we want to see this dye, the name will change, like barium solo for esophagus, barium meal for stomach, and barium follow through for small intestine, and barium enema for large intestine. So look at the picture here in the screen. If you look at this picture, there is some if sometimes there is a scenario like that, the patient having dysphagia, and this is the X-ray barium. This is the X-ray of, this is the contrast X-ray of the patient. So what is the name of the X-ray? The X-ray name is the barium solo. If you we look at the X-ray, then there is a distended esophagus is distended, and at the end there is narrowing. There is narrowing at the esophagus, and the esophagus is distended and dilated and retain of the contrast. If you look at this X-ray, the esophagus also distended, but not so like this X-ray. But here the narrowing is at one side, but here the narrowing is the mid midpoint, and in the on this X-ray the narrowing is the one side. And also if you look at carefully, then this margin is irregular, but here the margin is smooth. So if you see this X-ray, that is the esophagus, esophagus, the gastroesophageal junction is narrowing. That's why the dye and the proximal portion of the esophagus is distended. That's why the picture shows like that, uh, the distended esophagus with retain some uh, fluid or level, and the narrowing end is look like bird beak appearance, that is called bird beak appearance. So also, as the this narrowing is in the middle portion, this also called pencil tip or bird beak, pencil tip or bird beak. And if we look at this picture, you can see that this narrowing is at the middle, and both sides are smooth, both sides are smooth and narrowing in the middle. So this is also called pencil tip, this is also called pencil tip. So the clinical feature, the clinical diagnosis is, the question may be like that way: what is the name of X-ray? This is the barium solo X-ray. Name of the dye, barium sulfate. What are the findings present in this X-ray? if you look at this X-ray, then you findings of the X-ray look like that. Is smooth filling defect, already mentioned the filling defect is smooth proximal dilatation, bird-beak appearance, and absence of fundic gash. In case of, this is the typical feature of achalasia cardia. Achalasia cardia, this is the typical feature of achalasia cardia. That is also, this is a motility disorder. That's why there is the dysphagia that is more common on liquid than solid. As it is a motility disorder, the liquid cannot pass through this sphincter, but solid food, the solid food can pass through this sphincter, as solid food has a gravity. Due to gravity or weight, this solid food can pass easily, but liquid food cannot pass through this sphincter. That's why the dysphagia is more common on liquid than on solid. This liquid is retained in the esophagus. That's why the gas cannot pass from esophagus to stomach. So this, due to this liquid, the gas cannot pass through the, as this is the liquid, so gas cannot pass through this liquid. That's why the fundic gas is absent. Usually fundic gas is absent. The next question may be like that: what are the clinical feature? That is the dysphagia. The dysphagia in the achalasia cardia is more on liquid than on solid. This is a very important findings, as the liquid cannot pass through the sphincteric spasm, but solid food can pass easily due to its gravity. And also odynophagia, regurgitation of undigested food materials, and repeated chest infection. These are the clinical feature of the achalasia. If we see more elaborately of the clinical feature of achalasia, we can see that common in female between 20 to 40 years age group. Chest pain occurs in early stage. Patient with progressive dysphagia, which is more for liquid than to solid food, already mentioned the reason behind it. And the regurgitation and recurrent pneumonia are common. Regurgitation means the food pass from not pass through the stomach, it regurgitate to the, from esophagus to mouth. So this is one of the common feature. And heartburn is common. And due to this, the patient as this is a very long history, and patient may present with malnutrition and general ill health. Lung abscess formation is also one of the clinical feature. And odynophagia and weight loss, these are the clinical feature of the achalasia cardia. So uh, what is your diagnosis? Is the, this is a case of achalasia cardia, as because the narrowing is in the middle, the patient have dysphagia more on liquid than solid, and absence of fundic gas, and repeated change infection by clinical feature and radiological feature. By radiological feature, by radiological feature, this is a achalasia cardia, as the narrowing is that the middle and smooth surface with retention of fluid, and fluid level can be seen we in contrast X-ray. So this is a case of achalasia cardia. What type of disorder it is? It is a motility disorder. What are the clinical feature already mentioned? And how will you confirm the diagnosis? The barium is not the confirmatory diagnosis. The confirmatory diagnosis is esophageal manometry, to see the pressure on the esophageal sphincter. And this is the confirmatory. Esophageal manometry is the confirmatory diagnosis of the achalasia cardia. And what are the treatment options? There are several treatment options: medical treatment, minimal invasive treatment, and surgical treatment. Medical treatment, sometimes calcium channel blocker can help. the patient temporarily, esophageal dilatation, and other surgical treatment, Hiller's cardiomyopathy. This also the surgical option of the treatments, and so that and also the botulinum toxins also use. So these four are the treatment option for achalasia cardia. If you look this contrast X-ray, you can see that there is the narrowing is one side, not in the middle. And if you look carefully, this margin is irregular. This margin is irregular in shape. And if you we look at this contrast X-ray, there is apple core appearance, shouldering effect, and irregular filling defect. So this is the malignancy, the difference between achalasia cardia, the radiological difference between achalasia cardia and carcinoma esophagus is that the narrowing is one side, the margin is irregular, and not so many distension is here. And as this narrowing is one side, this is called red tail appearance. So what are the findings of this X-ray? There is an distended esophagus with irregular narrow margin is one side. And in this X-ray there is a shouldering effect, and also the apple core appearance, irregular filling defect. So these are the radiological findings of carcinoma esophagus, and it is differentiate from the achalasia cardia. So in case of carcinoma esophagus, what are the clinical feature? Progressive dysphagia, initially solid. The difference between achalasia and carcinoma esophagus is the dysphagia in case of achalasia is more on liquid than solid, but in case of carcinoma esophagus, initially the solid is more on the solid food. And progressive weight loss, regurgitation, chest infection, and also one of the important feature is hoarseness of voice due to recurrent laryngeal nerve involvement, and metastatic feature if it is metastasis to the lungs and other site of the metastasis, the feature of metastasis also present. These are the clinical feature of carcinoma esophagus. So what are the pre-malignant condition? The pre-malignant condition are that the condition may turn to the malignancy if not treated or untreated for a long time. It progress to the malignance one. So the question may be like that, or five malignant condition like achalasia cardia, Barrett's esophagus, corrosive stricture, reflex esophagitis, and Plummer-Vansen syndrome. These are the five pre-malignant condition that may turn to the malignancy if untreated. So what are the option of the carcinoma is what are the treatment option of the carcinoma esophagus? The treatment option may be surgery, radiotherapy, chemotherapy, surgery. And carcinoma esophagus patient usually present with very malnutrited and undernutritive condition. In this case, the staging more important in case of more usually we treated the cancer patient according to stage. But in case of carcinoma esophagus, the patient usually present with malnutrition. So the first priority is the fitness of the patient. So this is the exception of the other malignancy. With the esophageal malignancy, others malignancy, we treat patient according to the stage. But if the carcinoma esophagus patient is in early stage but unfit for surgery, then in this case curative surgery is not possible. The other option is the radiotherapy. Radiotherapy sometimes curative in case of squamous cell carcinoma, but in case of adenocarcinoma it is not helpful. So and the other treatment option, other modality of treatment option is chemotherapy. But if the cancer is if the patient is not fit for surgery, or curative surgery is not possible, and then in this case there are some palliative option like stenting, endoscopic laser, brachytherapy, bipolar diatherapy, argon beam, plasma coagulation. These are the option of palliative treatment of the carcinoma esophagus to patent the the esophageal channel, to maintain the nutrition of the patient, to prevent the dysphagia or odynophagia. By this method, we feed the patient by maintaining the patency of the esophageal lumen. So the treatment, the question may be already mentioned, the what are the findings and how patient present to you, and name free 5 malignant condition, how will you confirm, what are the treatment option, and what are the palliative option. All question are discussed. So in case of OSPE, there is you must remember that every time you answer in what, not in the elaborate things, but for understanding will some discuss in elaborately. So in OSPE, if you prepared for OSPE, if you prepared for OSPE especially, then you can score a good score. Actually, the OSPE is the summary of the whole things, but if we prepare for OSPE by especially time, by special time, then we can score a good score in the exam. So this all about the achalasia cardia and carcinoma esophagus. Next, another contrast X-ray. Uh, Sometimes in OSPE, we will give you a scenario based question, like that where a 50 years patient presented with some sort of dysphagia, or a younger patient with long history of peptic ulcer disease presented with vomiting. This is the barium. Actually, this is the barium meal. This is the barium X-ray. But as we see, we want to see the stomach, and the name will change, that barium meal. If we look at this X-ray, there is an hugely distended stomach, dye not pass beyond the pylorus, and you- and actually this X-ray, the this contrast X-ray is a series of X-ray, but in OSPE there is a and OSPE there is no scope to show you multiple X-ray. That's why we use a single X-ray, that with a scenario that you can understand what we want to see, what we want to know from you. So in case of contrast X-ray, conclude you cannot conclude a whole things, but due to auspiciation, we there is no scope to show you multiple X-ray. That's why we show a single X-ray with a scenario base, to understand you the actual what we want, or what need to want in exam. So this is another contrast barium meal X-ray, showing that the hugely distended stomach. Why we see distended? Because if we see this stomach in relation to the bone, this stomach lower margin reach up to the iliac crest, That's why we called it the hugely distended, and there is a mosaic pattern of the mosaic. There's a negative shadow and mosaic pattern of the stomach. This is the retained, nothing but retained food materials. And another X-ray show that if you see this X-ray, then the dye is passed already into the intestine. In this X-ray, this is the stomach, and then the dye pass actually when dye pass into the intestine, then the x-ray is taken. That's why we see the dye in the already goes to the intestine. If we see this x-ray, then this is an smooth surface. This is an smooth surface which is narrowing, but some dye pass into the small intestine. That indicate there is some partial obstruction, or there is some sorts of patency. That's why the dye pass through the intestine. But if we see in this x-ray, this margin is actually irregular. This margin is not regular like this x-ray. This is the irregularity of the. So what we conclude, what is this and what is this? If another x-ray, that the 3 x-ray shows that this is an hugely distended stomach, but it is not so hugely distended, and there is an smooth margin, and but there is an irregular margin. So the if we conclude this, this is actually pyloric stenosis, and this is actually carcinoma stomach. In case of carcinoma stomach, if we want to uh, differentiate the pyloric stenosis with the carcinoma stomach, we can see that the stomach is usually distended, more distended in pyloric stenosis, as the long standing history, and also patient have history of long standing peptic ulcer disease, burning sensation of the epigastrium. But in case of malignancy, usually the patient history is short, the age is more, sometimes the age is more, and if we see this contrast, there is an irregularity of the margin. So we can differentiate by this contrast the whether it is pyloric stenosis or whether it is carcinoma stomach. So question may be like that: what is the name of the X-ray? X-ray barium meal. What are the findings of this X-ray? There is an hugely distended stomach that reaches up to the iliac crest, and there's a retained food material which is mosaic type, and the margin is smooth. So this, what is your diagnosis? So diagnosis is the pyloric stenosis. But if if you want to describe this x-ray, there is an irregularity of the margin, so and stomach is not so much dilated, so this is the carcinoma stomach. So why stomach is dilated, already mentioned, as is reached up to the iliac crest. Why not antral malignancy, as the margin is smooth? As the margin is smooth, this is the key point, and also the stomach is not so many distended in case of carcinoma stomach patient also, and there is a retained food material. So how will you confirm this, whether it is pyloric stenosis or malignancy? This is the endoscopy upper GIT or esophagogastroduodenoscopy. Esophagogastroduodenoscopy confirm whether it is malignancy or pyloric stenosis. Actually, this barium meal X-ray nowadays is limited, as the endoscopy is more available, and in barium it is not confirmatory, but we can in endoscopy we can also see the diagnosis and also confirm the diagnosis. So in barium meal, actually the uh, use of barium meal is limited nowadays, but it is very important in your exam. How patient present to you. In case of in case of pyloric stenosis, patient have history of long standing peptic ulcer disease, that is burning sensation in the epigastrium, and also patient give you history of induced vomiting. The meaning is induced vomiting, that means patient induced vomiting by introduce his or her finger in the mouth, that is called induced, not only projectile. There is a projectile and induced. Induced is must be added to describe pyloric stenosis, vomiting of the pyloric stenosis. To describe the pyloric stenosis vomiting, you must mention the induced vomiting. How will you prepare the patient for surgery? This is very important, as in case of pyloric stenosis, the stomach is hugely distended, edematous due to retained food matter. There is a gastritis. So we need prepare the patient for surgery. Before surgery, we need prepare the patient at least usually 3 days preparation by gastric lavage. By gastric lavage, we introduce the normal saline and then suck out this normal saline, and we give patient liquid food for rapid absorption, not retained within the stomach. Mm, that that's why we use this preparation 3 days before surgery. Before surgery, by the term is by gastric lavage. The gastric lavage we introduce 250 to 250 to 300 ml normal saline in the stomach 3 times a day for 3 days, and after 10 to 20 minutes we suck the normal saline. By this procedure, we the retained food materials within the stomach is sucked out, and in between this time we can we can give patient to liquid diet. That's why it is absorbed more rapidly, not retained within the stomach. Why need stomach preparation? It's very important to need stomach preparation, as there is a chance there is an gastritis within the stomach, retained food material, edematous, and edematous wall. If we anastomose this edematous wall with the very narrow jejunum, that means the operation is the gastrojejunostomy. So the stomach is hugely distended and edematous with feature of gastritis. If we this stomach is anastomosed with the jejunum, there is a chance of loosening of the knot and chance of leakage, and this is very dangerous morbidity of the patient of leakage of the gastrojejunostomy anastomosis. So we before we operation we need stomach preparation is mandatory. This is another picture of hugely distended stomach of the pyloric stenosis. The I'll show you the another X-ray, another contrast X-ray of the another contrast X-ray. If you look at this X-ray, what we can see, what we can see, uh, sometimes if we can give you a scenario, a patient of 30 years old male having a history of pulmonary TB. Now patient present with fissure of intestinal subaqueous intestinal obstruction. This is the this is actually a barium contrast X-ray of the small intestine, and this is called barium follow through. The name change is to barium follow through, from barium solo, barium meal, and barium follow through. So the barium follow through X-ray, barium follow through X-ray. This is one of the contrast X-ray. Then here, if you look at this X-ray, what we can see, this is the terminal ileum. This is, and the terminal ileum is distended, and there is a narrowing of the terminal ileum. There is a narrowing of the terminal ileum, and cecum, which is upward. Cecum is in the right iliac fossa, but it upwards to up to the right hypochondrium, and it is deformed. So and also contracted. So the deformed, contracted with high of cecum, with uh, narrowing of the terminal ileum, with a proximal dilatation of the narrow segment. This is the typical feature of intestinal tuberculosis. This is the one of the most common disease in our country. So if we describe this X-ray, we can see that that is an barium follow through X-ray showing a narrowing of the terminal ileum with proximal distension and contracted high up deformed cecum. So my radiological diagnosis is ileocecal tuberculosis. Maybe it is the differential diagnosis, maybe Crohn's disease, maybe malignancy. And if you look at this X-ray, this is also a barium follow through X-ray, and here also showing this is the narrowing of the terminal ileum and also the proximal distension of the ileum. So what are the differential diagnosis of this X-ray? The differential diagnosis may be tuberculosis, maybe Crohn's disease, maybe primary carcinoma, maybe a lymphoma, carcinoid tumor, radiation enteritis, ischemic damage. So these are the most common cause of small intestinal narrowing of the small intestinal narrowing of the cause of the small intestine narrowing, and tuberculosis in one of the most common disease in our country. So these are the differential diagnosis of this X-ray. So question may be, what is the name of the X-ray? X-ray barium follow through. What are the findings present in this X-ray? Already mentioned, there is a deformed, contracted, high up cecum with narrowing of the terminal ileum and proximal dilatation of the ileum. What are the findings present in the already mentioned? What are the probable diagnosis? Tuberculosis, Crohn's disease, malignancy, and others. Differential diagnosis. You can put. What are the other investigation you can suggest? This barium follow through cannot confirm your diagnosis, but give you some clue of diagnosis. So to confirm your diagnosis, we can do a colonoscopy, that with an expert colonoscopist, he can enter into the terminal ileum, as tuberculosis is mostly affected in the terminal ileum. So he can take biopsy, and this biopsy will be the confirmatory diagnosis of the tuberculosis. So the other investigation may be colonoscopy with intubation of the terminal ileum and biopsy, and others investigation that help you to diagnose the tuberculosis, like complete blood count, MT test to exclude pulmonary TB, the chest X-ray, like that way. And in case of malignancy, others investigation, metastatic investigation, tumor marker also helpful to reach a diagnosis. Write down the principle of management. Actually, principle of management according to the diagnosis, maybe medical management, maybe surgical. So question like that way, how does tubercle bacilli infect the gut? Tubercular infection may reach the gut by secondary to pulmonary tuberculosis due to swallowing of the bacilli, ingestion of the bacilli with food, hematogenous spread of the bacilli from a focus in the lung or lymph node. These are the three methods of spreading of tuberculosis is small intestine. This is the second most common site of tuberculosis. So this may be due to secondary pulmonary tuberculosis. So you should must exclude pulmonary tuberculosis. Ingestion of the bacilli with food, it can enter into the food, or hematogenous spread of the bacilli from a focus in the lung or lymph node. These are the three common route of spread of the tuberculosis is in a small intestine. What are the type of ileocecal tuberculosis? There are two type of ileocecal tuberculosis. One is ulcerative and another is hyperplastic. If the body immunity is less, then the tuberculosis develop ulcer in the ileal region. But if there is an body immunity is more, then produce hyperplastic type of tuberculosis. The perforation and the complication, like in ulcerative varieties, the perforation is more common, and hyperplastic intestinal obstruction is more common. How patient with ileocecal tuberculosis usually present? Recurrent attack of lower abdominal pain, diarrhea is very important, weight loss, anemia, fever, mass in the right iliac fossa, subacute intestinal obstruction like colicky abdominal pain, distension, vomiting, and constipation. So these are the very similar to the malignancy, and it is very difficult by only clinical feature to differentiate the malignancy of the cecum and with the ileocecal tuberculosis. So very similar clinical feature of tuberculosis and malignancy in cecum and ileocecal region TB. How will you treat patient with ileocecal tuberculosis? Ileocecal tuberculosis, we can treat this patient by medical treatment and surgical treatment. In case of medical treatment, if there is patient have no feature of intestinal obstruction, perforation, and other, that we can treat the patient medical management, and patient can improve by this medical measure by anti-tubercular chemotherapy, isoniazid, ethambutol, pyrazinamide. uh, uh, these are the TB drug, anti-TB chemotherapy. We can treat the patient by anti-TB chemotherapy if there is no feature of intestinal obstruction or patient not present with perforation. But already mentioned, I mentioned that the ulcerative variety is present usually present with perforation and uh, uh, hyperplastic variety present with intestinal obstruction. If patient present with intestinal obstruction like feature pain, fever, sorry, pain, vomiting, distension, constipation, in this case we need surgery, and the surgery is limited right hemicolectomy as it is not malignancy. In case of malignancy, the classical right hemicolectomy is mandatory to for lymphovascular clearance. But is as if it is the tuberculosis is not malignant one, so no need of lymphovascular clearance. That is why we called it limited right hemicolectomy. But if the patient present with perforation, then the surgery also, in case of perforation the surgery is mandatory, and there are several options whether you do anastomosis or not, or exteriorization. It depends upon the condition, perioperative condition, patient age, presentation, the and fitness of the patient. So we can decide it perioperatively which procedure we do for perforation. So these are the indication of surgery, like if patient present with feature of intestinal obstruction and perforation, then surgery is required. This is another X-ray. I'll show you that. This is the another X-ray. Uh, there is a narrowing of the lumen with shouldering effect both side and irregular narrowing. This is a typical feature of the apple core appearance. This is the apple core appearance. The narrowing is the middle, and there is a shouldering effect. So this is the typical feature of apple core appearance. Middle narrowing and shouldering effect, irregular narrowing, and this is a typical feature of the colonic carcinoma. Typical feature of colonic carcinoma. If you look at if we compare these two X-ray, the resolution of this X-ray is more good than this X-ray. But why? What is the name of this contrast? Actually, it is the barium enema contrast. As we use dye parectally, that's why the name changed to the barium enema. Remembering that barium solo, barium mean, barium follow through, and barium enema. But in this contrast X-ray, we use another contrast. That is the another contrast is nothing but air. That is called double contrast barium enema. By using this double contrast or editing with the air, the resolution is more good. So this double contrast X-ray is more suitable to for diagnosis than the single contrast X-ray. So what is the name of the X-ray? Barium enema. If if the resolution is good, double contrast barium enema. What are the findings already mentioned? There is a narrowing of the lumen with irregular narrowing, and both sides there is a shouldering effect with apple core appearance. So what is your Powell diagnosis? Powell diagnosis is carcinoma colon. How will you confirm your diagnosis? We can confirm our diagnosis by colonoscopic and biopsy. By colonoscopy and biopsy, this is a very important investigation. We can diagnose and as well as we can confirm our diagnosis by colonoscopic and biopsy. Write down three clinical feature of carcinoma colon. Actually, carcinoma colon right side some clinical feature, and left side there is some difference between the right side colonic carcinoma and left-sided colonic carcinoma. Usually, right-sided colonic carcinoma present with lump, anemia, anorexia, asthenia, and in case of left-sided colonic carcinoma, usually present with parectal bleeding, incomplete evacuation, intestinal obstruction. This feature is more common in the left-sided colonic carcinoma. There are some difference between right-sided colonic carcinoma, clinical feature of right-sided colonic carcinoma, and left-sided colonic carcinoma. What other investigation you suggest according to findings? Whether it is malignancy, if the sorry, if it is malignant one, then you can go for the uh, staging investigation like ultrasonogram or CT scan of the abdomen, chest X-ray or CT scan of the chest. If it is rectal carcinoma, we can delineate the rectal carcinoma by MRI. But in case of colonic carcinoma, not rectal but colonic, then we can do an CT scan, contrast CT scan for better delineation and local staging. But for the distant staging, we use abdominal CT, we use chest CT, and also we can do tumor marker. Tumor marker actually give you a clue, and it is also helpful in post operatively follow up period. The tumor marker is very important in follow up period. If it is decreasing, that indicate the curative surgery was successful. If it is increasing, that indicate the recurrence may be a recurrence. That's why the tumor marker is increasing. So these are the other investigation you can do to diagnose the uh, to reach a diagnosis of the colon. This is another X-ray, another contrast X-ray. If you look at this X-ray, for what you see, there is a contrast X-ray, contrast X-ray. Uh, if we differentiate this X-ray, there is the contrast is not visualized in the left side, but visualized on the right side. This is actually intravenous urography. This is actually intravenous urography. We use contrast in this X-ray by IV route, and we take X-ray in time. If we take X-ray immediate after contrast, by we can see the nephrogenic phase, pylorus. We can see the kidney condition of the kidney, condition of the pylorus, condition of the ureter, condition of the bladder by according to the time of the X-ray. And if we if the excretion of the dye is delayed, we can decide that there is there is an obstruction of that side. So question may be like this: what is our diagnosis? Diagnosis, the as there is an the intravenous urogram showing dilatation of the kidney, so this is an hydronephrosis. This is the bilateral hydronephrosis, and this is the unilateral hydronephrosis. So what are the cause of this condition, and what is hydronephrosis? Hydronephrosis is a aseptic dilatation of the kidney due to obstruction. Aseptic dilatation of the kidney due to obstruction. How will you prepare patient for? Before going to prepare this patient, I will mention the cause of this condition. Cause of unilateral ureteric obstruction. The cause may be extramural obstruction. Extramural obstruction, that tumor from adjacent neck structure, cervix, prostate, rectum, colon, or sick may invade the ureter and that produce obstruction and hydronephrosis. Idiopathic retroperitoneal fibrosis, this is one of the clinical condition, can invade the can engulf the ureter and may produce hydronephrosis. Retrocaval ureter also one of the cause of the hydronephrosis. And intramural obstruction, congenital stenosis, physiological narrowing of the pelviureteric junction leading to pelviureteric junction obstruction, ureterocele, congenital small ureteric orifice, inflammatory stricture following removal of ureteric calculus, repair of a damaged ureter or tuberculosis infection, neoplasm of the ureter or bladder cancer involving the ureteric orifice, interluminal obstruction, another cause, the calculus in the pelvis or ureter, slab papilla in papillary necrosis in diabetic patient, analgesic abuser, and sickle cell disease can cause the hydronephrosis, hydronephrosis. So these are the cause of the um, mm, of this condition. And how will you prepare the patient for this investigation? Actually, how will you prepare the patient for IV? IV need some prepare. Actually, usually we give patient to 3 days preparation, and at this 3 time we use Lagzena at night time. We use less gas producing, less fiber diet to visualize the X-ray more, for visualization, good visualization of the X-ray. And we also reduce the gas by some medication to reduce the intra-abdominal gas. So as this is an X-ray, we take measure to visualize the good X-ray with good X-ray. So that way we can advise the patient, and we can prepare the patient for 3 days before investigation. Name contrast used in this X-ray, actually it is sodium diatojoate. This contrast used in the IVO is sodium diatojoate. Another before going to another contrast X-ray, I will mention you a picture. So this is an T tube. This is look like a T, and this is called T tube. And if you look at this picture, this is the biliary, and this is the hepatic duct, this is the cystic duct, this is a common bile duct, and this is the duodenum. After exploration and after removal of the stone in the CBD, we usually use T tube for, if the facility, we use the T tube as if we not confirm that whole of the stone can be extracted. That's why we use this T tube T tube paraoperatively and postoperatively to see or confirm whether all stone is extracted or not. Actually, it is better to use kaleidoscope to see the CVD. the kaleidoscope is enter into the cystic duct and visualize the CBD whether there is no stone, or whether any stone or not. If there is no stone, there is no need of T2. But if you cannot confirm that all stone are extracted, in this case we usually and routinely, sometimes in previous day we routinely use this T tube, and this T tube is help you whether a retained or missed stone is present or not. By this tube we use contrast. In this way, this contrast visualize the biliary tree, and we can see whether any negative shadow or filling defect is present or not, that indicate there's some stone present or not. This is an contrast X-ray, T-tube contrast X-ray. This is the T-tube, and this is the biliary tree. The gallbladder is already resected, and this, if you look at carefully, then this CBD is dilated. This CBD is dilated, and there is a negative shadow. There is a negative shadow or signal void area in the lower CBD that indicate a retain or missed that indicate a missed or retained stone. This indicate a retain or missed stone. So this negative shadow may also found in air bubble or blood clot. If we change the position of the patient, then in case of air bubble, if the patient position is upward, the air bubble is goes to the up. But in case of downwards, the air bubble, the head downwards, the air bubble is goes downwards. But in case of stone, it is the opposite. If the head is upward, the stone is dislodged to the lower, and if the head is downward, the stone is uh, dislodged in the upward. So we can differentiate it whether it is air bubble or it is a stone. So this negative shadow has three DT. Is one is air bubble, one is a stone, air bubble, and another one is clot. So this is the contrast X-ray, and by this X-ray, if there is a negative shadow in the CVD, that is missed stone or retained stone, in this case need intervention, and this intervention, as ERCP nowadays is more available in our country. So if the size is if the stone size is within the limit, actually it is 1.5 centimeter, we can extract this retained stone by ERCP easily. But if it is impacted and more large, then in case of others method like open method, laparoscopy method can use. But previously, when the ERCP is not so available, in this case the T tube, the tract is dilated by dilator, and stone can be extracted from this tract. This is the another option that is called Barhani technique. Nowadays it is almost obsolete, as the ERCP is more available in all over the world. So what is T-tube cholangiogram? Actually it is nothing but is the contrast X-ray. That contrast is introduced through the T-tube to see the whole biliary tree. That is called T-tube cholangiogram. The why T-tube cholangiogram is done as T-tube cholangiogram to see whether any negative shadow present or not. If there is no negative shadow is present, that indicate no retained or missed stone, we can remove this T-tube easily. But if there is a missed stone or retained stone, we cannot, we it is not we need further intervention to remove this missed stone. So what are the findings in normal T-tube cholangiogram? Actually normal T-tube cholangiogram findings is there is no single signal void area or negative shadow irregular filling defect, and dye easily pass CBD to the duodenum. And another question, is it par or postoperative? Is it actually postoperative? Because in case of paraoperative, some instrument may retain in this X-ray, but there is no instrument, so that indicate it is the postoperative T-tube cholangiogram. When T-tube cholangiogram done, actually we do T-tube cholangiogram 7 PUD 70. What are the parts of T-tube? Already we show a picture of T-tube. This is the actually T shape, and this is the short limb. The short limb has two angle. Actually, one angle is obtuse angle and another is acute angle. Actually, lower angle is acute angle and upper angle is obtuse angle. But in case of silicon tube, there is no difference between the two limb, as it is very soft, so it is very easy to remove. That's why no need of angle. But in case of this tube, have two angle. This angle is acute angle and this angle is obtuse angle. To for oblique removal, we gentle pressure on the tube, and it is extracted through the uh, tract from the CVD. And this tract due to the reactive change, no bile is leakage from this. The bile is passed through the to the duodenum. So when we remove this, there is no negative shadow. Patient clinically patient is good. There is no jaundice and no pain, and with free flow of bile in the duodenum, that indicate there is no stone in the CVD, and we can withdraw, we can remove the T tube. This is the another contrast X-ray. No, not showing. This is a side view endoscope tube. This is a side view endoscope tube. This goes from stomach to the duodenum up to the ampulla of the vater. As it is side view, we can see the ampulla very easily. So in case of to see the ampulla, we use endoscope, that is side view endoscope. So this is the endoscope. We see the side view endoscope. After seeing this, we use we use catheter. We can introduce the catheter both in the pancreatic duct or in the CVD, and then we mm, we use the dye through this tube and visualize the biliary tree. Both the CBD and pancreatic duct can visualize by this X-ray, as and it is called ERCP, endoscopic retrograde cholangiopancreatography. Endoscopic retrograde, as it is not the bile flow is this direction, we go this direction, that is retrograde. In that is retrograde. So we call is the retrograde we call this retrograde cholangiopancreatography, as both the biliary tree and pancreatic duct visualized by ERCP. And why this film is called ERCP, as there is an endoscope is visualized on the X-ray, so it is called in ERCP. And this is also the pancreatic duct, which is dilated with some stricture, multiple stricture. So this is the pancreatic visualization of pancreatic duct, and this is the visualization of pancreatic duct. So by ERCP, we can visualize both the common bile duct and also the pancreatic duct. Actually, this ERCP nowadays not recommended for diagnostic purpose. It is usually used in therapeutic purpose. So this is the describe the X-ray. What are the findings? The findings are there is a visualization of the CBD and pantida with multiple negative. So this one negative shadow with dilatation of the CBD, that is called retained stone in the CBD or lithiasis. And if it is there is a dilated pancreatida with multiple stricture, maybe due to chronic pancreatitis. These are the findings of the two X-ray. What are the indication of ERCP? Actually, ERCP indicated for the therapeutic purpose, like to remove the choledocholithiasis, to remove the worm, remove the foreign body, for stenting in case of malignancy, for palliative purpose. We use this ERCP, and also papillotomy in case of papillary stricture. These are the therapeutic use, and nowadays the ERCP is absolute for diagnostic purpose. We use is therapeutic purpose. What are the contraindication? Contraindication: if there is an gastric outlet obstruction, if there is a gastric outlet obstruction, it is not possible to pass this endoscope. And if their patient had a history of gastrojejunostomy, then also it is not possible to pass this endoscope into the ampulla. These two are the contraindication of the ERCP. What are the complication? Complication may be pancreatitis, hemorrhage, perforation of the duodenum, perforation of the CVD, and also cholangitis. As we use dye in this area, if there is an stricture in the intrahepatic biliary tree, dye may stagnant on the biliary tree, that produce severe cholangitis of the patient. These are the complication of the ERCP. This is the last slice of today our class. Here we see that there is no endoscope, but there is a visualization of the biliary tree, and also the pancreatic duct, and there is a negative shadow both in the gallbladder neck and in the lower CVD. Actually, it is the MRCP, magnetic resonance cholangiopancreatography. This replaces the ERCP, diagnostic purpose of the ERCP. In ERCP nowadays, as MRCP is non-invasive, there is no invasive. This is an investigation. No need of use of dye, no need of use of any other intervention. So it is an non-invasive investigation that diagnose the biliary tree condition of the pancreatic duct. That's why it is widely used to see the biliary tree, especially the choledocholithiasis, the pancreatic duct stone and condition of the pancreatic duct. Actually, this MRCP replace the diagnostic ERCP. So this is the same simple investigation, and also it is not expensive like that of ERCP, and so it is widely used for diagnostic purpose. And this is all about the contrast X-ray of our today lecture. Thank you all. Thank you very much.